Good morning and welcome to our seminar on Micronized Purified Flavonoid Fraction, MPFF. As for my disclosure, I'm a Chief Scientific and a Clinical Advisor to Vita Support MD company. MPFF is composed in 90% by diosmin and in 10% by hesperidine fraction, with hesperidine, diosmetine, linarin, and isoroifolin. The micronization process is important as the intestinal absorption almost doubles with the decreased diameter of MPFF particles. This improvement in intestinal absorption also explains the advantage of MPFF over an equivalent dosage of non-micronized diosmin, demonstrated in a clinical study in patients with chronic venous insufficiency. After a 2-month treatment at a dosage of 2 tablets daily, MPFF was shown to provide 30% greater clinical efficacy on all the most common symptoms of CVI, such as leg heaviness, paresthesia, or leg pain. In the same study, after 2 months treatment, the decrease in ankle circumference was significantly greater in the MPFF group. Pharmacological effects of MPFF were well described in a recent review article on venoactive drugs. These effects are mainly related to the mechanism of action as inhibitor of cell adhesion molecules with NADPH oxidase inhibition and decrease in reactive oxygen species production. It translates into clinical benefits with reduced leukocyte adhesion, inflammation, reduced microvascular permeability, reduced edema, improved venous tone, capillary and lymphatic function, leading ultimately to improved chronic venous disease symptoms and patients' quality of life. The cascade of events in the chronic venous disease was summarized in a key paper by Professor Bergan and colleagues. For the clarity of this presentation, I will follow Professor Bergan's schema when quoting MPFF studies, starting with the first 2 levels, venous hypertension and inflammation. In a novel model of venous hypertension, MPFF significantly improved microcirculatory changes, was more effective than diosmin alone, and was the only one to prevent venular enlargement with synergistic action of diosmin and the active flavonoids in MPFF. 4 weeks treatment with MPFF significantly improved leg venous tone expressed as elastic modulus in patients with symptom of CVD compared to control with no treatment. Markers of inflammation were extensively studied in patients with chronic venous insufficiency and showed the involvement of leukocytes adhesion molecules such as ICAM1, VCAM1, and vascular endothelial growth factor. 2 months treatment with MPFF significantly decreased the level of vascular endothelial growth factor in CVD patients with skin changes. MPFF reduced also the levels of ICAM1, VCAM1, and mitigated the inflammatory reaction in a dose-dependent manner. Another study of antioxidant balance in women with varicose veins demonstrated the decrease in levels of pro-inflammatory cytokines, endothelin-1 and tumor necrosis factor alpha. In a granuloma rat model, MPFF reduced edema formation as well as inhibited synthesis of prostaglandin E2, F2 alpha, and thromboxane B2. MPFF reduced also cell migration towards the inflammatory focus and improved histological aspects of the acute inflammatory reaction. The COMET assay analysis of blood lymphocytes from patients with chronic venous insufficiency compared to healthy controls revealed increased oxidative DNA damages and showed also a significant beneficial effect of MPFF, reducing these DNA damages. A diabetic rat model served to study the oxidative stress and confirm the protective effect of MPFF. The authors suggested MPFF as a complementary treatment for prevention of diabetic microangiopathy. In another rat model, reflux flow rates across the saphenous valve after 3 weeks of venous hypertension were significantly diminished in the group treated by MPFF compared to the vehicle group. CVD patients with edema treated with MPFF versus placebo for 60 days also demonstrated a reduction in venous reflux time measured with ultrasound. Chronic venous reflux and vein wall changes result in capillary hypertension and leakage. An in vivo model of hamster cheek pouch was developed specifically to test drug effects on the microcirculation. In this setting, an ischemia followed by reperfusion provoked capillary hypertension, and leakage was visible thanks to administration of a fluorescent product. In this model, MPFF anti-hyperpermeability effect was significantly higher than that of diosmin. Hesperidine, linearin, and isoroifolin had anti-leakage effect similar or greater than diosmin, and altogether this study confirmed synergistic action of MPFF components, each of them contributing to the drug efficacy. Capillary hypertension and leakage further aggravate inflammation and cause edema. Anti-edema properties of MPFF were demonstrated in several double-blind placebo-controlled studies using ankle circumference outcome. Recently, Kakos and Professor Nicolaides published a meta-analysis of randomized controlled trials with MPFF in chronic venous disease. After a systematic review, 7 trials were included in the meta-analysis, with a total number of patients 1,692. The authors concluded that MPFF is highly effective in improving leg symptoms, edema, and quality of life in patients with chronic venous disease. When talking about quality of life, we must mention the RELIEF study. This study compared patients with and without venous reflux. Pain was assessed by the visual analog scale and leg circumference by the legometer, a validated device allowing precise measurement in the standing position. Patients were treated with 1,000 mg of MPFF daily for 6 months. Both groups showed a significant efficacy of MPFF, improving pain and edema. The RELIEF study validated CIVIC, Quality of Life Questionnaire specific to chronic venous insufficiency, in several languages and in 18 countries. The improvement of quality of life paralleled the clinical improvement, and this for all four dimensions of quality of life: physical, psychological, social, and pain dimension. Among all causes of secondary lymphatic insufficiency with lymphedema, non-cancer related causes represent 93%, with venous disorders in 80% of cases. MPFF activity on lymphatics was evaluated in experimental studies with lymphedema and in patients with severe chronic venous insufficiency, where MPFF increased functional microlymphatic density, improved microlymphatic drainage by decreasing microlymphatic diameter and pressure. In post-mastectomy lymphedema, double-blind, placebo-controlled trials demonstrated that in patients with more severe lymphedema, MPFF increased lymphatic transport on lymphoscintigraphy, and there was a trend for reduction of lymphedema volume. Another double-blind trial in filarial lymphedema included two groups of patients. Group A received MPFF and antiparasitic drug, and Group B antiparasitic drug alone. Both treatment capsules had similar appearance. Patients were followed for 270 days after 90 days of treatment, and lymphedema volume was measured by water displacement volumetry. Group B had no significant changes in edema volume. On the contrary, in Group A with MPFF therapy, a 63.8% reduction in edema was observed. The article concluded that MPFF was safe and efficacious in reducing lymph volume in filarial lymphedema. Among different indications, I will only briefly mention venous leg ulcers that will be presented in detail by Dr. Mellin. Other potential indications include perioperative therapy before and after phlebectomy, investigated in the DEFENSE study, pelvic congestive syndrome, evaluated in a randomized controlled crossover study, and orthostatic transient reflux in patients with telangiectasias and reticular varices. I will spend some time on hemorrhoidal disease, frequently forgotten venous problem, underdiagnosed and undertreated. In acute hemorrhoidal disease, in a randomized controlled trial versus placebo, MPFF treatment efficacy reached 78% at third day and 100% at sixth day. Acute attack dose is 3 grams for 4 days, followed by 2 grams for 3 days, and 1 gram in prevention of episodes. In the same study, bleeding was significantly reduced from the third day of therapy. MPFF was also beneficial as periprocedural adjunctive treatment, decreasing bleeding after hemorrhoidectomy, together with a significant improvement in pain, tenesmus, and pruritus. In pregnant women, MPFF reduced acute hemorrhoidal episodes by more than 50%, and the mean duration of episodes from 3 to 1 day. MPFF property as NADPH oxidase inhibitor may open the door for additional indications. NADPH oxidase inhibition is involved not only in venous and lymphatic disorders, but also in pathomechanism of atherosclerotic lesions, lipids metabolism, and in arterial thrombosis. Indeed, we know now that an overproduction of reactive oxygen species intervenes in whole spectrum of cardiovascular pathologies. And MPFF demonstrated reactive oxygen species scavenging properties using in vitro and animal models. An interesting finding came from the research related to COVID-19, looking for potential protecting molecules. One of the published works stipulated that hesperidin can be beneficial thanks to the inhibition of inflammatory cytokines, increased cell immunity against infections, and blockage of COVID virus entry into the lung cells. There is certainly a lot to be discovered about flavonoids. What we can certainly affirm that MPFF is one of the most studied and frequently used treatment of chronic venous and lymphatic disorders, as well as for hemorrhoidal disease. MPFF reduces edema by improving venous, capillary and lymphatic circulation, increasing venous tone and decreasing inflammation. MPFF improves venous symptoms and patients' quality of life. MPFF improves also skin trophic changes, venous ulcer healing, and improves hemorrhoidal disease symptoms. MPFF was a subject of numerous publications, systematic reviews, meta-analyses, book chapters, and was recommended in several clinical practice guidelines all over the world in chronic venous disease and hemorrhoidal disease. Thank you very much for your kind attention.